My name is Rajesh Karbanda. I work in Oxford in the United Kingdom. I'm a cardiologist, and one of my jobs is that I am the lead of the National UK Registry. And so over the next 10 minutes and 20 minutes or so, I'm going to give you a background to the registry and tell you why I think it's important. I'm going to tell you about how using that data can influence practice and how we might improve that over the coming years. So the background really relates to concerns that were raised about a particular hospital's performance and outcomes, and that was in the 90s. And after a public inquiry in the United Kingdom, there was a call for much more transparency and publication of operator-specific outcomes based around surgery. So this was a really important time that changed UK practice. And it established a big program of clinical outcomes research that is focused around a range of specialities, not just cardiology, but a whole range of interventions ranging from surgery, orthopedic surgery to cardiac procedures. Its initial purpose was to monitor the mortality from pediatric and adult cardiac surgery, but now it has increased to include other cardiac interventions, including angioplasty, structural heart interventions, and a whole range of heart failure and myocardial infarction. And it looks at both procedures and their complications, but also in terms of service delivery, for example, the door-to-balloon times for acute reperfusion treatment. It's developed into a tool not only to assess operator performance, but also for comparisons between hospitals in terms of their processes, with a way to improving care by benchmarking practice. So in summary, it has two things. One is about outcomes, and that's to say whether your service meets specifications. But secondly, about quality improvement. And we can only improve our services if we know where we are and use those as a benchmark from which to develop. This is a technical diagram, and I don't expect you to digest it, but it illustrates how we can get data from practice, how we can convert that to knowledge, and how we can define outputs that we can then monitor. This is the typical audit cycle which you will be familiar with. But in addition to this, it gives us information about local variations in practice. It allows us to benchmark. And I think in the future, it will now tell us about device-specific outcomes in the real world and also longer-term outcomes of the procedures which we undertake. I think some of us as procedural cardiologists are very pleased when we see that our patients leave hospital and we look at the early outcomes, but actually we need to understand the longer-term outcomes and accumulate that data. This is a timeline of what's happened with TAVI. And you can see that over the past 20 years, we've had very robust randomized trial data. But if you drill down on these randomized trials, they are selective populations done in selective centers with very short-term, sometimes long-term outcomes, but not clinically relevant always to real-world practice. And this is my diagram of where registries fit in. We focus on large clinical endpoint trials, but we need real-world registries to put some of those results from randomized trials in context, particularly in terms of longer-term outcomes. So whilst clinical trials provide information about safety and effectiveness very well, as I've said, the trial populations are often selected, sometimes by geography, and follow-up is often limited. And real-world registry data allows us to look at the actual treatments in the patients that we treat in our populations. So let's turn to TAVI. TAVI has developed over the past 20 years, and in the UK, new treatments are assessed for their clinical and cost effectiveness. TAVI in the UK was started in 2007, but as part of that national rollout, the funding bodies and the National Health Service wanted to evaluate and make sure that they had information about all of the procedures that were conducted in the country and the outcomes. And that was the beginning of the TAVI registry. Every TAVI procedure that is undertaken in the UK is entered into this registry. So we have knowledge of about 40,000 procedures that have happened since 2007. It's a data set that evolves, and I'm sure, as you all know, when you are doing these procedures, you can make the data set either very simple or very complicated. But it's a compromise of how much information we can gather. But we gather clinical information. It's not industry funded. It's done by the operators. And we have about 100 fields for each TAVI procedure. And that includes the demographics, the clinical background, and procedural features. Remember, this is a procedural database, and that has its advantages and its disadvantages. We measure early outcomes such as death, stroke, complications. So really it tells us about where it's being done, how it's being done, and what the early outcomes are. So in the United Kingdom, we have 32 centres providing TAVI for a population of about 68 million. I understand in China that number is more like 500 centres. So clearly there's a huge difference in the volume of TAVI that might be happening. But over those 32 centres, you can see there is geographical spread. And that's important for us to understand that there is no major national variation. This is what has happened to TAVI activity over the past 10 years. The blue line tells you total activity. And for our population of just over 60 million, we undertook about 8,000 TAVI procedures, and that gives us a rate of about 114 per million population. That is much lower than some other European centres, and I think it's quite important to ask, what is the correct number for your population? Because there is no clear right answer to this. The other things you can see on this are that about 1/5 of our work is what we call urgent TAVI. I want to tell you that that is not emergency TAVI. Those are very small. Shock, that's a very, very small proportion. These are patients who are admitted and can't be discharged from hospital because of heart failure or very poor ventricular function. And rather than an elective procedure, they have what we call an urgent procedure. And that is about 20% of our workload. This is data I've managed to get from China, from your national registry. And as you can see, your numbers are growing, as we saw in our studies. But what you can see is data is limited to about 166 rather than the 500 centres. So there's obviously some selection here, and these numbers may not be as accurate as we might want. But this speaks to data quality and data assurance. And I think as we move forward, we're going to need to address these issues. So how much TAVI do we need to do? It's now becoming the standard treatment. And this nice paper from the group that you see here did a modelling exercise for how much TAVI we might need in the UK. And they've suggested a number of 50,000. So we're doing 8,000. We need to grow to 8,000. And I did a back of the envelope calculation, assuming a 3% rate of aortic stenosis in the Chinese population, similar to ours. And you need to do about 1 million TAVI. So, you know, you've got a lot to go, and you're going to grow over the next years. Even if it was half of that, that's still 500,000. So big volumes of TAVI in your population. This is information looking at what's happened to surgical activity. The blue line is the total activity for aortic stenosis, either by TAVI or surgery. The grey line tells you what's happened to our surgical activity in the United Kingdom. There was a big drop in surgical cases over the COVID pandemic in 2021. And that really has failed to improve. And that transition from TAVI being the dominant treatment for aortic stenosis over surgery happened in about 2018-19. And I'd be interested to see where other countries are in this crossover. But we know, for example, that some of the European countries had a much earlier crossover, and I'm sure other geographies will have a later crossover. This graph tells you who we are treating. The proportion of patients under 75 really hasn't changed in the UK over the past 10 years. The proportion of older people over 85 has gradually reduced, and we've seen an increase in that group between 76 and 85 in our practice. But let's compare this with what's happening in the US, for example, where the guidelines are different. On the far left of this graph, you can see that the proportion of patients under 65 years of age having TAVI as their treatment has really doubled over this time, and the number of surgical patients has reduced. So unlike our practice in the US, younger patients are being treated. But what about China? Well, in China, your population is different. You can see from this epidemiology study that your patients are at least 10 years younger than the patients I'm treating in the United Kingdom. You can see that the level of calcification is higher. You can see that even in China, regional differences exist in the patterns of aortic stenosis. And the reason this is relevant is that some of the outcomes that I'm going to show you may not be applicable to your population because you're dealing with a different pathological process of disease, you're treating more complex patients, and in addition, you need to focus much more on those longer term outcomes than the population which we're treating. Similar to the American population, you're taking on a younger cohort, but with a more complex disease platform. I understand you have a much higher prevalence of bicuspid disease, and that brings with it more complexities like dilatation, more horizontal, more calcium. So let's turn now to how we're doing those procedures. As well as who, the what, and the how, most of our procedures are done under conscious sedation with a percutaneous, non-surgical femoral approach. So if I compare that with what's going on in China, you can immediately see that you are doing fewer emergency cases, and that's because the programs are different. But you can see that your use of general anesthesia here is almost 90% of cases, whereas ours is the other way around, 90% conscious sedation. So there are some differences, and they may relate to practices, but it's quite interesting. Whenever you see variation, it's important to ask, why is there such difference in practice? 20% of the cases had surgical percutaneous closure. Again, very different to our practice. And it's interesting to understand why those differences exist and which might be improved. As part of the work that I do, I set benchmarking standards. And in the UK, these are the benchmarking standards that I ask our centres to aspire to. So we know there's a volume outcome relationship. We want to increase centre volumes because we want to maintain quality. We want those to be done what we consider to be best practice standards, which is non-general anaesthetic, percutaneous access transfemoral. And we want to aim for early, safe discharge. This isn't about discharging patients that are unsafe to discharge, but we know from an efficiency perspective that safe early discharge is important for healthcare resource utilisation. So let's now turn to outcomes. The orange line is the reduction in mortality that's occurred for elective cases over the past 10 years. Urgent cases have a higher mortality. I told you they were 20% of our workload, and they have an almost double mortality. The other signal that we see is that by 30 days, there's an increase in mortality after discharge. And I'm still trying to understand the reasons for this early procedural death when we consider TAVI to be quite a safe procedure. This graph shows you the reductions in major vascular access complications, bleeding, and stroke. Again, this gradual reduction over the past 10 years with improvement in outcomes, and these complications are occurring at less than 1% frequency. So we've seen improvements in procedures, mortality, and outcomes. This is the rate of moderate or severe aortic regurgitation. As you can see, dropping from nearly 6% down to under 2%, and pacemaker rates showing a reduction as well over time. So how else might we use this national registry? We need to provide device-specific outcome in the UK now. And the other thing that we need to do is start to provide risk-adjusted outcomes. Now, risk-adjusted outcomes are a really politically sensitive area because at the moment we don't have validated risk tools. But the other point is that in the Chinese practice, actually, you're dealing with different population. You might need to develop your own risk adjustment tools, and you can't do that if you don't have a large cohort of well-characterized patients. And we're in the process of developing that for the UK to try and understand how we might look at those. And then in terms of what funding bodies and higher process in terms of healthcare utilization and funding bodies need, they want this sort of data to inform health policy. This is early unpublished data showing you early death, and in our case, nearly 20% mortality at 2.5 years, and a 10% incidence of heart failure. And what I want to know is, why are those patients there? And is that a device-specific related, or what are the factors that drive this quite significant mortality early after the procedure? So in summary, I think these data are really important to understand who is being treated, where they're being treated, and how they are being treated. And that will vary by country and geography and unit. And so for comparisons, you need that. We need to understand whether these variations in practice and outcomes exist and how we address those to make sure that patients are getting equitable treatment across geographies and regions. And it also provides us an opportunity that randomized controlled trials don't give us about the long-term outcome and the actual performance of devices in the real world. With that, I thank you, and I'm ready to take any questions. Thank you.